Hi, the question that you may be having out there, and I get this question a lot, almost every day. And it might be from you, the patient, the client, and the family and parents. And the question is always short term Suboxone use versus long term Suboxone use. Let me couch that question for you in a way that you can sort of make sense of the very question itself. Okay, you're sitting in front of me and you've been to 5, 10, 15, 20, 30 rehabs. And my job as a physician, first and foremost, is to educate you about the pathology of what you're dealing with. Okay. And I would like to do that because I don't think it's done enough out there or oftentimes done correctly out there, depending on who's giving this information. And I don't mean to say there's not other great practitioners out there. I don't mean to say there's not others working very difficult in the field that you may have come across that try to educate you. But the first thing a person needs to understand is what the disease is. And then their question, in this case, short-term versus long-term Suboxone, will make sense. Think about it. When you go in and let's say, God forbid, you're diagnosed with cancer and you know nothing about it. You know, a guy tells you you have AML or CML, whatever, CML, okay? Chronic myelogenous leukemia, okay? They give you a very, very robust, scientifically based understanding of what you're suffering from. And then they tell you what the treatment options are. And they don't just make that stuff up or base it on their beliefs. They base it on the science that's out there. And the science is all about probability and statistics. Okay. So you come in here and you may have been to 20, 30 detoxes. You've spent the last 6 months, 1 year, 10 years, 15 years dealing with, let's say, opiate addiction, heroin addiction, whatever it is. And the first question that you have is, I want to get off Suboxone as soon as possible. And I just find that it baffles my mind because to me, it's out there and it's very clear how this medication is used. And there's a concern for this. First thing I want to tell you is that question itself kind of presupposes that the fact that the possibility that you are against medication-assisted treatment, you think that it's a crutch, you think it's trading one addiction for the other. These are the things that kind of question usually pops up in my mind when you sit in front of me and ask that question, and I have to ask myself or turn around and ask you in a very kind, loving way, you know, how long are you going to go through this vicious cycle? And why is your thought about, oh my God, I need to be completely clean, and you use the term clean as applied to whether it's heroin, fentanyl, pills you're buying off the street, or any other opiate substances that's caused your life to be where it is right now, okay? And you're thinking you're trading one addiction for other and nothing changes. First point I want to make to you, the definition of addiction is not something you have to take every day. I'm going to repeat this because it's important. The definition of addiction is not a substance that you have to use every day. The definition of addiction is much more complex than that, okay? It happens to be that substance that you have to use every day, okay, over time, your use increases, your tolerance increases, and all of your higher cognitive function and all of your social function starts to get narrowed and concentrated on gaining and using that substance. That's why there's so many consequences, everything from your physical health, including hepatitis B, hepatitis C, HIV, soft tissue infections, pulmonary edema, overdoses. These are the physical things, and potentially death. all the way to the social things where you might lose your wife. Maybe you lose your girlfriend. Maybe you're going to get kicked out by your parents from the house. You sell everything you have. You might even go further and sell your own self for that. You have legal problems. That's the definition of addiction. Now let's go back to this idea of trading one addiction for another again. We said, no, it's not just replacing one substance for another that you have to take every day. Let's just take that issue regarding pills or medication or substances that affect your brain or your body. Okay. A diabetic has to take insulin every day. Are they addicted to the insulin? Do we use that term? Someone with certain heart issues, certain blood issues has to take a blood thinner every day. Otherwise, they're going to have a heart attack or stroke out. Do we call that an addict? So the very idea that you need to take it every day does not imply, and it's neither sufficient or necessary to call it an addiction. And nobody ever seems to think about that as they come sit right in front of me where you may be sitting, and they go around this merry-go-round over and over and over and over again. And asking that question, that's the first thing I want to educate you about, okay? If the substance is something that you have to take every day, that is not what addiction is, okay? That is part of addiction, but that is not what addiction means. If it did, all of these other things you have to do every day would be addiction. Do I have an addiction to food? No. Do I have an addiction to water? No. I need it to not get sick, and I need it not to die. But that's not what addiction means. Number two, second part of this question, where does this all come from? It's the psychological, social, political, economical stigma towards substance abuse or addiction. Okay, we got it all wrong, and we're wired wrong about it, okay? If we were a society that didn't have that kind of stigma, this question regarding a substance you have to take every day would not even arise. And now let me go back to that substance, Suboxone, having to take it every day, let's say in long term. What does that substance do for you? Well, it prevents hepatitis C, hepatitis B, HIV, soft tissue infections, overdose, death, being so high and euphoric that you're not the same person, changing your brain chemistry in a negative functional way, no jail time, you don't lose and sell your soul and everything else you have. So that's what Suboxone does. So it sort of puts it on the category of all of the other medications I'm talking about. So do we really want to have this discussion that Suboxone, you're trading one addiction for the other, and you have a concern about short-term versus long-term? Now, let's get to that question of short-term versus long-term, okay? Which one is better and why? Here's my position on it. And I know it's backed up by data. Until recently, there's some talk about this short-term thing, but I don't think the data is any strong. I'm going to tell you this. Suboxone was never approved for any kind of a short-term use or taper, okay? It's often used in a lot of programs, detox programs, to switch from heroin to Suboxone and taper you in this uncomfortable way. And what does it really do? So let's say you want to pay thousands of dollars to go to a detox program. And what is the point of detox? Okay, there's no detox in that sense that you detox off the med and you're supposed to go on. Addiction is a disease, and the disease continues. All they've done when you go into a program and substitute Suboxone for heroin is the body does not have any judgment towards opiates. Okay, it's one opiate that's replaced by a legal opiate, and it's tapered down. And I could have done that with the heroin, except this is measured, and it's safer, but it does nothing for your addiction or relapse potential. Okay. Really, there's one area that there's some data to this effect. It makes potential overdoses afterwards worse. For every other issue of being an addict, going into a detox or a program and using Suboxone for short-term taper really does absolutely nothing for your addiction to opiates. It really is replacing one opiate for another and saying, okay, you're done. You're not done. Two, it is, in a positive way, the safe, legal way to taper you off opiates. I'm going to use that general term, opiates. Three, so that's good because it's controlled. You know how much you're getting, and it's legal, and it's measured. But three, it leads to a potential relapse that could be devastating, because now that you've taken you off of that high dose of heroin or fentanyl or whatever you're on, where you've built some tolerance, now I've used the drug to taper you down, to fill those opiate receptors. I have done nothing for the long-term clinical management of your opiate abuse, and you're going to go out there and you may relapse. So it's not at all indicated, the clinical term that's used for that short-term taper. And more than likely, for probably almost most people, it doesn't do anything in terms of long-term sobriety and recovery. This is a maintenance medication. This is a chronic medication, and you are supposed to get titrated up to the right clinical effect dose, usually between 16 and 24 milligrams, not 2 or 4 for most people. Again, I'm doing generalities here to cover as many people as I can. And then you're supposed to be maintained on a dose where every day you do not have cravings and withdrawal. Now let's talk about, so if all of that is understood, the question itself is telling me, when you're sitting here telling me that this is your concern, it's telling me that you have a concern that's based on a false sense of reality imposed by society, culture, institutions, yourself, your family, of what addiction is. Two, there's no such thing as detox. Addiction is addiction. What it should be called, and I think they call it now with SAMHSA, is medically managed acute withdrawal. Okay? That's it. Makes it more comfortable. And that really doesn't exist anymore if you really think about it, because the time that it takes for me to transfer, if everyone was doing it the right way, the time it takes for me to transfer you from any opiate to Suboxone is a few hours to a day. And some people I've seen 2 to 3 days. And you don't need much, maybe a little bit of benzos, maybe a touch of clonidine, maybe a touch of baclofen, very safe medications. So, there's really no detox. And number 3, this does nothing for long-term recovery from addiction, whether it's a few weeks to a few months after that rapid withdrawal. And now this, if all of that is accepted, you may still want to ask me, okay, how long do I have to be on it? And here's the truth about that. I don't know, and the science doesn't really know, but clinical experience does know. And there's a select group of patients that may have to be on it for life. And you have to ask yourself, well, is that okay? Well, it's not great to have to be on a pill, but you have to evaluate the benefit versus the risk. Where is your life now? What are you doing? How many things have you missed? Finishing college, losing that job, your body may be all tore up from abscesses, you have legal problems, you don't have a dime to your name, okay? And you could risk overdose, death, and violence at any moment, versus I put you on a medication, all of that is gone, and I tell you that, okay, you have to be on this medication for a certain amount of years or maybe for life. once you're on that medication, how do you know when to take someone off? If they have truly built the connections from the frontal cortex to the midbrain, and there's a change in architecture and pharmacology, we can start discussing tapering. And this is where people run into trouble again. And I get so many comments on YouTube about this being the worst this, worst that. If that conversation comes up, and when you're ready and your physician advises you appropriately, it might be 6 months, it might be 6 years. That part itself is as tricky and problematic because it's just often not done right, whether it's the patient's expectations and them doing it themselves, or sometimes the clinician may not have a real understanding of what this means and what are the benefits and the risks. That taper should be done if you are ready, as deemed by the clinician and discussed with you, over as long as it takes, 2 months, 6 months, 2 years. Small tapering doses, constant clinical evaluation to see that you are comfortable in terms of withdrawal symptoms and your mood, and your life is progressing as it did before. And the clinician and you should be ready to go back up and down as necessary by your clinical presentation. And one of the things I do with patients when it's that time or they really want to do that is I suggest to them and let them know, listen, so let's say you are on 8 milligrams a day, twice a day, okay? 16 milligrams. And you get, let's say, by this time, 60 a month, and everything else clinically I've deemed is good to go. I let you know that, you're going to get your 60, but here's what we're going to do, for example, okay? I do it sort of like benzos. And I say, here's, you take 8 milligrams in the morning and 8 in the afternoon. Is that what you take for the day? Yes, doctor, I've been taking this for 5 years. Okay. And I want to make you be at ease, and that I'm not going to take this medication away. And I do it kind of like I do benzos. I'm like, I'm going to write you for your usual 60. Your life is great. Everything's going good. Tell me which dose is the one you like the least, or you don't need the least if you had to pick one. Like, well, doc, sometimes my afternoon dose, I even forget to take, and I got to remind myself, so it's the least important one. I say, great. That afternoon dose, cut 1/4 of it off, for example, and starting tomorrow, okay, instead of taking the 8 milligrams in the afternoon, take 6 milligrams in the afternoon. Do that for the next week. In fact, before you go to bed or right when you're about to do that, pre-medicate yourself with, for example, if they're okay, either 600 of ibuprofen if they have no stomach issues and I don't have concerns for bleeding or kidney issues, or 1,000 milligrams of Tylenol if I decide that they don't have any liver issues, and just take one of those for the next 2 to 3 days. And let's try this for 1 week. I want you back here in the office in a week to tell me how that went. And from that point, I proceed. That would be how I would go about a Suboxone taper when it's time. That is how I would explain to patients whether they should do short-term or long-term. If you like this video, please click above to my left for other videos related to this topic. Please subscribe to our channel and ring the bell so you can support our cause in beating opiate addiction. Thank you very much.